Hello students, this is our second lecture and we're going to talk about porphyria. Okay, so there are all sorts of interesting diseases out there and lots of them are quite exotic and rare. And our lecture is about one of these diseases, one of these rare diseases that nobody think about and often goes undiagnosed. So what is porphyria? Porphyria are a group of rare inherited disorders of heme biosynthesis, resulting from a deficiency of one of the enzymes on the heme synthetic pathway. So in the previous lecture, we said that heme is synthesized by 8 steps, and there is a specific enzyme responsible for each step. So any defect or deficiency in one of these enzymes, this will result in a disease called porphyria. Heme production is impaired. When this happens, when there is a deficiency in one of these enzymes, heme production is impaired. But reduced feedback inhibition of ALA synthase, which is the rate-limiting step, may maintain adequate heme levels at the expense of overproduction of porphyrins or their precursors. So, if there's a deficiency in one of these enzymes, heme production will be impaired. And this will lead to decrease in the negative feedback inhibition on this enzyme, on the ALA synthase, which is the rate-limiting enzyme of this pathway. This will lead to increase the activity of this enzyme. And when this enzyme having increased activity, this will lead to increase the precursors of this pathway in order to maintain adequate level of heme. So, porphyria can be classified into, according to the clinical presentation, into acute porphyrias and cutaneous porphyria. The acute porphyrias can be further classified into Ppg Synthase Deficiency, acute intermittent porphyria, hereditary Porphyria, and variegate porphyria. The cutaneous non-acute porphyrias include Porphyria Cutenatarda, congenital arthropoetic porphyria, and protoporphyria. Now, this classification, like I said, it's based on the clinical presentation of the patient. However, there is another classification, and it's based on the major site where the enzyme deficiency is manifested. And it's classified into either arthropoetic or hepatic. Now, these two types, the congenital arthropoetic porphyria and the protoporphyria, it's called arthropoetic porphyria because the enzyme deficiency occurs in the arthropoetic cells of the bone marrow. While the rest of the porphyrias, the other four, and this porphyria, it's the Porphyria Cutenatarda, called hepatic porphyria because the enzyme deficiency occurs in the liver. Now we're going to start with the acute porphyrias. And the first one is Ppg Synthase Deficiency. So this enzyme, from its name, from the name of this disease, this enzyme will be deficient. This is an autosomal recessive condition and in which Ppg concentration is not raised, although that of ALA is. So ALA will increase, this enzyme will be deficient, and this will lead to increase concentration of ALA. And this condition is very rare. Now, the other 3 acute porphyrias are autosomal dominant disorders, and they will have latent phase and acute phase. So they will have a latent, which is like a hidden phase, and acute phase, where the symptoms will be manifested. Acute intermittent porphyria, it's due to Ppg deaminase deficiency. This enzyme will be deficient, and there is increase in urinary ALA and Ppg concentration. So these two will be increased, and this will lead to increase their concentration in the urine. The latent phase of acute intermittent porphyria is asymptomatic. The patient will have no symptoms during the latent phase. Hereditary cuproporphyria, it's due to cuproporphyrinogen oxidase deficiency. So this enzyme, cuproporphyrinogen oxidase, will be deficient, and there is increased fecal cuproporphyrin excretion. Variegate porphyria, it's due to protoporphyrinogen oxidase deficiency. This enzyme, protoporphyrinogen oxidase, will be deficient, and there is increased fecal protoporphyrin excretion. Now, the acute phase. The life-threatening acute symptoms that occurs in acute intermittent porphyria, variegate porphyria, and hereditary cuproporphyria are clinically identical. And the acute attacks are more common in women, usually occurring first between the ages of 15 to 40 years, and they're very rare before puberty. During the acute attack, the patient will suffer from psychological symptoms like delusions. Also, they will suffer from seizures, insomnia. Patient will have vomiting and severe abdominal pain that mimic the acute abdomen. Also, there is high blood pressure, and the urine will turn into red or brown, and peripheral neuropathy. So all those symptoms will occur during the acute phase of the acute porphyrias. Acute attacks may be precipitated by a variety of factors, including drugs. It's a wide range of commonly prescribed drugs like barbiturate, estrogens, and these drugs will increase the activity of the enzyme ALA synthase, so they will precipitate an acute attack. Also, alcohol can also precipitate an acute attack, and menstrual cycle. It's because of the hormonal changes that occurs during the menstrual cycle. They can precipitate the acute attack. Stress, infection, and calorie restriction or fasting. And this may be due to increased demand for heme. So this will also precipitate the acute attack. Now, how to investigate a patient with suspected acute porphyria? With the exception of the first disease, with the exception of Ppg Synthase Deficiency, that in which case ALA concentration would be expected to be raised, attacks of acute porphyria are associated with elevated urinary excretion of Ppg. So Ppg will be increased in the urine. And Ppg may spontaneously oxidize to form uroporphyrin when exposed to light and air. Ppg will spontaneously oxidize. See here, the urine will be turned in color. This is due to Ppg will convert into uroporphyrin if exposed to air and light. Now, if you see here, this is the left urine sample. This is a freshly taken from the patient, while the right urine sample, it's the same sample after exposure to sun. And this is showing the classic darkening of the urine. So fresh, random urine specimen protected from light should be sent to the laboratory for the quantitation of Ppg. If an acute porphyria is confirmed, the concentration of porphyrins in the urine and feces should be measured. And a negative results exclude an acute porphyria, provided that the sample is taken during the acute attack. provided that the patient is symptomatic at the time of sample collection. In between acute attacks, the excretion of Ppg may return to normal. So we have to take the sample during the acute attack and the patient should be symptomatic. Treatment of acute porphyria. We give the patient heme arginate, given by slow intravenous infusion. This will result in reduction in ALA and Ppg concentrations, and thus reduce some of the features of acute attack. Now, the other type of porphyria, it's the cutaneous non-acute porphyrias. And from its name, the cutaneous means it will affect the skin. Non-acute, it means that the acute attacks will not occur here. So we're going to start with the Porphyria Cutenatarda, which is the most common type of porphyria. Porphyria Cutenatarda is the most common type of porphyria. And patient with Porphyria Cutenatarda, the skin is sensitive to minor trauma. Their skin will be very sensitive to trauma, particularly in sun-exposed areas. And the most common presenting feature is a blistering on the back of the hands. So the patient will present with these types of blisters on the back of their hands. Less commonly, the lesions appears on the face. There's increased facial hair and hyperpigmentation. Acute attacks do not occur here, like I said, but this type of porphyria is associated with hepatic damage. So in Porphyria Cutenatarda, the liver will be affected. So what happens in Porphyria Cutenatarda? The basic defect is the inability to convert uroporphyrin to cuproporphyrin due to a deficiency of uroporphyrin decarboxylase. So this enzyme will be deficient. The impaired conversion leads to accumulation of uroporphyrin and porphyrins intermediate between it and cuproporphyrin, and these will deposit in the skin and are excreted in the urine in increased amounts. Now, the other types of porphyria, the Arthropoetic porphyrias. These are two rare inherited disorders, are associated with the accumulation of porphyrins in erythrocytes, because the enzyme deficiency will occur in the erythropoietic cells of the bone marrow. Here, the acute attacks do not occur, and ALA and Ppg excretion are normal. Congenital erythropoietic porphyria, it is inherited as an autosomal recessive characteristic due to uroporphyrin synthase deficiency. This enzyme will be deficient. And when this occurs, when this enzyme is deficient, uroporphyrin 1 is instead will be produced spontaneously. So this is an enzymatic conversion of hydroxymethylbilane to uroporphyrin 1. And uroporphyrin 1 is then converted into cuproporphyrin 1 by the same enzyme that acts on the 3 form, which is uroporphyrin decarboxylase. And this product will be cytotoxic. These two is cytotoxic. So blood, erythrocytes, and the plasma uroporphyrin 1, there is an autooxidation, and these uroporphyrin 1 will be converted to uroporphyrin 1. And in erythrocytes, this is very high. There will be a very high concentration of this product, and this starts from infancy onwards, and there is severe photosensitivity. Those patients will suffer from a severe photosensitivity. As you can see here, there is increase in uroporphyrin 1. Porphyrins are also deposits in the bone and teeth, and the teeth will be brownish and pink in color. Hirsutism, which is increased growth of hair also, especially on the face, also occurs, and there is also a hemolytic anemia. Urinary porphyrins concentrations are grossly increased, and although the fecal porphyrins levels are less so. Okay, so porphyrins will increase in the urine, but fecal porphyrins levels are less so. The last type of porphyria is a protoporphyria. This is an autosomal dominant disorder due to ferrochelatase deficiency. So in this condition, ferrochelatase enzyme will be deficient. And the protoporphyrin 9 concentration are increased in erythrocytes and in feces. Here there is mild photosensitivity, but there is hepatocellular damage that will lead to liver failure. So the photosensitivity will be less here, but the hepatocellular damage will be more and lead to liver failure. Investigations of cutaneous non-acute porphyria. So we measured the porphyrin concentration. If there is increased concentrations of erythrocyte porphyrins, this may suggest protoporphyria or congenital arthropoetic porphyria. While if there is increased concentration of urinary porphyrins, this may suggest Porphyria Cutenatarda or congenital arthropoetic porphyria. While there is increased concentrations of fecal porphyrins occurs in protoporphyria. Treatment of cutaneous non-acute porphyria. In Porphyria Cutenatarda, we do a vein section to draw blood. It means drawing blood from the patient to decrease iron stores. And in erythropoetic porphyrias, we treat those patients by sunlight avoidance, like for example using a sunblock to avoid the symptoms of this type of porphyria.
Cranky.
So I prepared for you a video to summarize the lecture.
Any thoughts?
And to recognize the signs and symptoms.
File?
And also get familiar
Previous
with the
tests revealed
presentation
nothing that
of
would cause
porphyria.
abdominal pain or the
let's
mood
watch it.
swings.
MRIs were clean, which means he's probably fine. He doesn't seem paranoid. He shows no signs
No,
of...
it means we have no idea what's wrong with him.
You're cutting him open?
Oh, hold it. There's no need for exploratory surgery. Dr. Cameron has a diagnosis.
No, I just think it's premature and maybe irresponsible to do exploratory surgery before we know he's actually sick.
No.
Goldstein found nothing but a distended bladder.
Neurogenic bladder isn't causing the pain.
It also doesn't cause personality changes. On the other hand, it would completely account for Cameron's diagnosis. The patient's completely healthy.
Give me the video of the surgery. This is the problem.
Unbelievable. Tremors in the muscle fiber.
That's not peristalsis. That's abdominal epilepsy.
Is it some sort of neurological problem?
Time bomb in his brain.
Nurse? Nurse? I'll see the
What happened? What's wrong?
My toes, they were numb, tingling, then nothing. No pain, nothing.
So we had an intermittent syndrome that presents with abdominal pain, polyneuropathy, paranoia, and delusions. Now here's the thing about acute intermittent porphyria. They'll jump you in a dark alley, beat the crap out of you, leave you bleeding. But it wears gloves, so no fingerprints. Doesn't show up in blood tests, urine tests, nothing. Unless you catch it red-handed, in the middle of an attack.
There's only one way to confirm AIP. urine sample made during the attack.
And there's no way to predict when you'll have another attack.
Sure there is. Acute intermittent porphyria has very specific triggers. Barbiturates, alcohol, high levels of protein will set off an attack.
Which trigger do you think set off Mark's?
Not the faintest idea. That's why I'm going to give in the combo plate. All of it. Straight from the bladder. That's as fresh as it gets.
It's still yellow.
Move.
What?
You think another light's gonna make the difference?
Organic chem. More light, more oxidation. Does it ring any bells? Start the patient on 150 milligrams glucose, 75 milligrams hematine.
And thank you.